Okay, so we'll start quickly on the definition for the quality of life. Um, we ask why you need to assess the quality of life from pharmacoeconomic perspective. We will discuss that later on the models and why we can, if we have valid data on the especially cost utility measures, we can combine them to assess the CALI and make decisions based on that. So we need to assess the importance of quality of life. We'll go through this throughout the coming 2 days. We need to assess the outcomes from patient perspective to measure CALI. Now there is a trend, especially actually we have many medications, the pipeline, and sometimes you'll find a marginal difference actually in the survival. This is, I encourage colleagues also not always to have the survival as the primary endpoint. And this is happening actually in many situations, especially like cancer. We always look for the survival. No, we need to consider when we expect the new medication, the impact to survival would be not that much, to consider the quality of life. There are conditions like the low back pain, patient with disabilities. We need to also to consider the quality of life as primary outcome. Also, there is these areas, as we said, like, also quality of life matters. And there are also different options that we'll discuss later throughout these 2 days that we can also consider the quality of life in the assessment. We are all aware of the quality of life, the physical, mental, and social well-being. I would encourage everyone to use the term health-related quality of life rather than quality of life, because the health-related quality of life, we are focused on the health aspects. We are not engaged here with the education, with the social, with other things that job like employment, all these things. But health-related quality of life will be more helpful term to use in our language. This is the first figure actually was in my thesis, because I was looking at the use of the quality of life, and you can see that with few studies that they were using like the quality of life, then you can see throughout the research like we have sharp increase of utilization of quality of life in medical research. We're interested, as we mentioned, to live longer as possible. This is the death, to be normally functioning disability, and also to be free from pain is the psychological or physical or social symptom, this discomfort, and also to be free from the adverse reactions. So we understand, we are working on the quality of life simply because we need to assess the start of the quality of life use actually was mainly to understand the things from the patient perspective, and also health insurance companies played actually a major role, especially in the States, to get the quality of life involved in the management and in the standard setting. We sometimes discuss the outcomes. I was consultant for the National Guard, the International Medical Research Center in Saudi Arabia for the National Guard, King Abdullah International Medical Research Center. We have like consultancy clinic for the investigators who would like to do studies. So when I discuss with them, sometimes, no, for this study, I believe that we should consider the quality of life. They will shy from that because we are not familiar. Like if we, I encourage any physician, any healthcare provider to understand the concept of the quality of life, either a physician or a nurse or pharmacist, because we need to consider that in management of symptoms, in management of disease, to understand the impact of disease on patient perspective. So we don't know how to analyze them, how to interpret the data. This is sometimes we try to avoid them because we don't feel that we are fit in them. This is why we have to get other colleagues involved in the research team to make our research project stronger. So the quality of life is the way how we see the disease from patient eyes. So this is why very important for us to consider. If I ask, for example, about the number of emetic episodes, this is what we assess the symptoms. In my practice, for example, patient coming to me saying that they have vomiting, we ask them about frequency, and this will have some clinical indicators. If you ask the patient himself or herself, how bad is your nausea, we are now talking about the impact of this vomiting, frequent one, on the quality of life. Dr. Muhammad is one of the, I consider him regional experts in the pharmacovigilance. And this is very important, Dr. Muhammad and other colleagues also, for the When we consider the ADRs for medications, we have a major issue globally, actually, not just in the region, with compliance with medications. People, they don't take their medications regularly because of some ADRs. So if you don't ask about the nausea, whether it's affecting their quality of life or not, they will not, a simple example, they will not take their medication. So we need to consider the impact of these, quality of life on patient life, and to translate the symptoms from clinical perspective to the impact on patient lives. I'll skip this one for cancer. So we are meeting today to discuss the impact of the health economics on the decisions, the healthcare setting. And this is very important to consider the quality of life tools in our evaluation. And this is, and also the impact from different angles. And this is why I consider the quality of life lecture to be added here. So in order to move from subjective in nature to something that we can quantify, we need to have different tools. And this is the tools that I'll discuss in a minute. We'll have different types of the quality examples. If we look for financial decisions, why we are gathering today, we will look at the CALI, and my colleagues discuss that later, because we need to combine the mortality, morbidity data, and to assess, to have one figure. For example, medication A, the impact on CALI, for example, is 0.7, medication B, 0.5. This is how you can combine the patient will live longer with a good quality of life at the same time, so we can compare them. DALI is the opposite of CALI. DALI is the number of years of life lost. And this is we can consider that especially in preventive medicine, to assess the impact of smoking cessation programs, breast cancer screening, different interventions, to see that if you have this intervention, you can reduce these DALI. We know the components, physical, mental, social, and we sometimes also quantify the very important when we select questions for the questionnaires or tools for the quality of life assessment. We need to ensure that they are valid for use for this particular setting. For example, you'll find questionnaires that will be valid for the general population, questionnaires that not will be, for example, valid for one disease, not for another disease. You'll find, for example, like some questionnaire could be used for arthritis, the same questionnaire, they don't have the validity for example, hypothyroidism or cancer. So you need to ensure that your questionnaire have a good sensitivity for assessment of quality of life in that disease area, and also the language. I have seen different colleagues also in the region with this, one of the issues that we see. They don't have a validated questionnaire to be translated. They translate that without doing the reliability testing for the questionnaire. So please ensure that, first of all, if you have disease, for example, you are working in cancer, you need to ensure that this questionnaire is valid for use for cancer patients. Then to consider, are you doing a clinical trial or cross-section study? Because questionnaires we use for clinical trials should be sensitive for change. So we need to consider the setting for the use of that tool. And also when we translate the language, is it valid for translation? For example, I know the questionnaires for the aortic questionnaire I'll discuss shortly. It's validated in 5, 6, 10 languages, so we can utilize them. But I cannot just take a questionnaire and translate that myself and use it for my study. I have to do first my homework and doing the valid and reliable translation for that questionnaire before tool. And I have to respect also the owners of that questionnaire. And this is another thing that we need to ensure that this is a good practice to be also followed. So we have certain criteria that a comprehensive, credible, accuracy, sensitivity to change, especially for clinical trials, and also to the constructability, the availability. So reliability has different types from, we can assess reliability, but reliability just a general term that if you do the questionnaire, you be the questionnaire, that we have the same outcomes. If you do the assessment and your colleague do the assessment, we have the same outcomes. This is in addition to the internal that you discussed, the correlation between the question, in the questionnaire, for example, if you have some question that trend toward positive, the other should be trained the same trend for the same concept. Okay, I'll just go now through different types of questionnaires. We have something we call generic questionnaire. These are generic questionnaires. For example, I want to compare the health rate, quality of life for Jordanians compared with Saudis, for example, or the Kuwait people. I want to assess the impact of general interventions for the general population, the community, and want to assess this impact for the general population, I'll use these questionnaires. If I want to compare with the quality of life between different illnesses, I want to see the control of chronic illnesses in Jordan. I want to compare the quality of life between different these areas, between diabetes, hypertension, heart failure. I cannot go for disease-specific condition here. I have to go for a general questionnaire. This is an advantage. You can compare different populations, different disease areas, but this also adds to the limitation of the general questionnaires, because when the questionnaire is more general or more the generic, will not be that sensitive to changes for that disease areas. For example, if I have the SF-36 for a general population or for patient with controlled diabetes, it will not be that sensitive to changes with management of diabetes. This is why we have to consider, am I having this questionnaire for the cross-sectional study to assess the impact? I need to look at the objectives and decide accordingly. For example, using that for a clinical trial to assess change of 10, 20% in the impact of the controlled disease on patient quality of life diabetes. Now, in this case, I'll go for diabetes-specific scale or questionnaire. So we have to consider the setting where we use the quality of life. I'll skip this disease specific. These are the commonest ones. Actually, I like the SF-36, but as I mentioned that, we should know where to use this questionnaire and the setting for that. For example, I'll tell you about the SF-36. We did screening for adult hypothyroidism. We look at the subclinical and the overt hypothyroidism. For the subclinical hypothyroidism, we found significant difference in all quality of life domains in the SF-36 compared with the euthyroid, the general population without impairment of thyroid function. But when we consider the same tool, actually, for the measurement, I included, in addition to the thyroid-specific questionnaire, in the clinical trial to assess in the crossover clinical trial, it was insensitive to changes. So there was no value for that in the clinical trial. So you see, when we did that as cross-sectional study, as outcome screening, differences were significant compared with the general population. But when I assessed the change in the quality of life for the subclinical hypothyroid patient with himself or herself, after having trial of thyroxine treatment as a replacement versus placebo, they were useless. So this is very important to understand where to use the questionnaire and which questionnaire to use. Utility measures that are great, actually. We can utilize them in the economic evaluation, but we have to ensure that the tool used there is specific for that population, for that language, and for that disease area. We mentioned that the generic questionnaire, the major limitation for them, that they would be that insensitive to major changes or to even subtle changes for that disease population. This is why different disease areas population scales have been developed, and you'll find a lot in the literature, but please ensure that this questionnaire is valid for use in your language and in your setting. And if you are doing a cohort study or clinical trial or cross-section study, you need to ensure that this questionnaire is sensitive for that setting. There are disease-specific questionnaires that sometimes they have been, working especially in the breast module for the aortic or the colorectal cancer module of thyroid or diabetes. We find that, they will include symptoms related to that disease, the impact of these symptoms. We mentioned earlier the vomiting. So like we said, the immunosis, if you ask the patient or the frequency, this is a clinical question. If we ask the impact of this immunosis on their quality of life, this is the quality of life assessment. The limitation for them, they are not available for most conditions, and also you cannot compare. For example, I have this questionnaire for arthritis impact scale. I cannot apply it for the general population. Sometimes in the ideal situation, if we have patients with a chronic disease and we are giving treatment for that patient, our ideal situation is that we need that patient to be controlled with the treatment, and they should live life, a good quality of life, similar to anyone without the disease. So this is the poor control, especially in the MENA region, I should say, for chronic illnesses. We need to evaluate that to compare patients with that chronic disease who have been treatment for 10 years. They should not have a significant difference in their quality of life compared with someone who is healthy without that disease. And here we have a limitation to compare the general population of that disease area. This is why we keep emphasizing that you need to understand the setting when you select the questionnaire. There are different questionnaires. I'm in favor always of the EUROTIC because translated different languages, they keep, we have questionnaire EUROTIC for all cancer patients, and we have also subtypes for special, like we have the breast module, we have colon module, and these are really of great value. We have been trying them in different studies in the region, worldwide, and they are of great value. I like to use especially the EUROTIC questionnaire, but you need to discuss, to assess the setting where to use it. I'll skip these ones, and you see this is also, you can use the quality of life internal patients. As I mentioned, one of the areas why we ask the quality of life, especially in clinical research, these days there are many medications in the pipeline. You'll find maybe the impact on survival is not that much. Unfortunately, even the pharmaceutical companies, sometimes they don't publish their study, especially when it's pharma-initiated study, because they don't find a significant difference in the primary outcome. This is now pharma should publish, and the research should be done by independent body, but until now, most of the medications are initiated by clinical pharma, by the pharma companies through CROs, and if the medication is not that significant, they will not publish it. And this is why I think that this step should be taken from the pharma, even for their products, should be done in independent body, because sometimes they focus mainly on survival, just the original survival on certain clinical outcomes. Some medication, they have a major impact on quality of life, especially when the existing medication is a good one, but you have something better, and then here the quality of life can play a more role. Especially if the incidence ADRs are lower or the impact of certain aspects of quality of life is better. Okay, sometimes we have, it's not whole questionnaire. We have a questionnaire, we call it dimension specific. You look at one area of quality of life. For example, the Barthel Index for Disability, or the Big Depression Inventory. You look at one aspect of quality of life and you use the tool. Method of administration. Which one, Dr. Samah, you prefer to use in the region here? Yes.
The easiest here in our region and the most acceptable would be face-to-face interview.
Thank you very much. In the UK, we are like having the envelope, the questionnaire inside prepaid envelope. We send it through general practice or through our department, and they will receive them back. Here, because people are not familiar that much with the use of questionnaires, even studies, if you leave it even face-to-face, but we'll discuss that in a separate workshop or training about how to handle sensitive questions, how to do this. Sometimes we prefer to be, according to the target group, actually, to be completed by the subject. But in general, actually, telephone interviews, they are not really common practice to be used. I don't encourage that in our population. People are now really focused on the computer-based or web-based. I don't think we reach most of the target audience in our region. I think we need to encourage, but with this pandemic, we learn to focus mainly on the internet, but especially when our patient groups, if it's for general population, you might use the web-based, but I think for certain populations, I think you need to have either self-completed or face-to-face. I would encourage in our region, face-to-face and a private, and also ensuring the privacy in our region. So we can use them for primary outcomes in our research and clinical trials, or we can consider them in the secondary outcomes. And many times, actually, we focus on the ADRs from certain medication, and sometimes we don't use it. But if we look at the impact, whether it has minor, moderate, major impact of quality of life, this will answer us better, actually, to make decisions in clinical settings. There are factors, please, when you do, sometimes we have like SF36, ready questionnaire. I want to use it for my patient with, for example, diabetes or diabetes impact scale. Please always have another questionnaire to be done by you as an investigator to look at the factors that will affect the quality of life. When I do things, for example, we did something on the breast cancer, colorectal cancer here sitting in Jordan. I need to look at the treatment patient that they received, the stage, the grade, the pathology, metastasis, the other comorbidities. Even we ask sometimes about the social settings. Sometimes, for example, someone who have depression. Maybe they have, for example, a partner or family member or someone died recently, and this affected their response to the depression scale. It's nothing to do with the disease itself. So you have, these are the confounding factors, the predictors of the outcomes, quality of life. So please don't just give the ready-to-use questionnaire and give it to your subjects. You have to do your homework to look at all factors: age, gender, education, disease stage, grade, treatment received there, other things in life that could affect the financial situation. They have to do the questionnaire by yourself, and this will help you actually to publish your results, also to adjust the outcomes and get more valid results. By the way, just one last thing. Sometimes we do research, especially clinical trials, and when we say, for example, we exclude, this is why we'll discuss tomorrow the real life data, because in clinical settings, you will have long lists of exclusion criteria. And sometimes we include only that specific group, and in real life, you have something different. And this is why we need to ensure also the phase for the post-marketing surveillance and studies to assess the outcomes of the management and adverse drug reactions in our healthcare settings. I will finish in a minute, I think. Okay. I've seen this in many trials. Patients with psychological conditions, or they have some impairment, they are excluded. But if the disease area, for example, someone with terminal cancer, I don't expect they'll have, they have some mental impairment because of that. We should not exclude them, especially in the outcome. This will affect actually the impact. If you have a clinical trial on terminal cancer patient, or someone with disability, someone with poorly controlled diabetes, or someone with really poor heart failure, I don't think, when we exclude them from the study and the outcomes, I think we are affecting the real response from that medication. Because if you have a major improvement in quality of life, especially in the mental well-being for these subjects, I think you are really minimizing the impact of your intervention, whether it's the intervention could be medication, could be a service, could be physiotherapy, could be et cetera, et cetera. So I think we need to consider these things in our exclusion criteria, because they will underestimate the real value of the medication or the intervention. And the major limitation I've seen in the region, I've been in and out of the Middle East for the last 10, 15 years. We discussed the quality of life always in clinical research, investigator resistance. And I said, we can sort this issue by having more training, more engagement of colleagues in research related to quality of life, and also to inform the decision maker about the impact and the importance of the quality of life. And the cost, also we have to respect the copyright of those who develop the questionnaire. I have to pay them fees. Sometimes there is license fees. I always include that in my budget. So please don't just start to do study, utilize something, you find it from you take it from your colleague, or you find something on the web and you use it. There is license there. If you develop any questionnaire tool, any intervention, you always like others to respect your copyright there. So I think I received many times emails from tools that I use from different PhD students or master degree or other clinicians. They want just a copy of that questionnaire. I always decline that, saying you need to reach this email to get the license and pay the fees. You have to respect other people's work. Okay, interpretation of the data is not really easy. Even when I work with our statisticians on the analysis, they always hate me when I include the clinical quality of life in the analysis, because it's a headache for them to combine and adjust different questionnaires. Then I start asking them about the correlation and predictors and to adjust the outcomes. But it's really something that they will enjoy once you see the outcomes. But at least try to get the key messages for your colleagues to understand the key concepts of the physical, mental, combined scores, domains. But these things will come with time. As I mentioned earlier, that I was resistant to include that in my clinical trial for the hypothyroid patients, but I found later that this is really of great value and we need to include that in our research. I will finish now in a minute. One thing, if you think that your disease areas has a major impact on the mental health, please try to go also for the psychological being assessment. In many practices in the UK, I think Anas also can share this with me. In the UK, they have patients are waiting to see their GPs. Sometimes we give them questionnaire, GHQ questionnaire to fill, to screen for mental well-being, especially in places or cities or areas where we think there is issue there with the mental health. These tools are great in assessment of the psychological well-being impairment in the general population. Also, we can utilize some of them, like the hospital anxiety depression scale, GHQ, in clinical research, other surveys, cross-sectional studies, or clinical trial. So they are very important. We cannot have a clinical interview with anyone from general population or anyone coming to our practice, for example, to have a comprehensive psychological assessment. These tools are of great value to pick as screening tools for those with mental health impairment. We can utilize them in our research, in our clinical settings, also in our in different settings. But as I mentioned, these are not diagnostic in nature. So we need to be, these tools, for example, they develop them like the GH or hospital anxiety depression scale. They, for example, if we interview 100 patients with moderate or severe depression, or give them the same questionnaire, we should pick them from the clinical judgment. We should receive nearly the same number of those picked from that questionnaire. This is why I just add the general health. We use them mainly if you consider that this disease would have an impact on the mental health, and you expect this impact is very important from the assessment or the monitoring of treatment. I think it's good to include them in your studies. Cali, I think my colleagues will cover this more, but we need to look at the importance of Cali, especially in the cost-utility analysis. The first question we started with, you have a cancer patient to live 1 year with good quality of life or 2 years with poor quality of life. We can answer it as a more valid, more scientific approach in combining the life years gained with good quality of life in one tool that is Cali, and we can utilize that in our economic evaluation and make judgments based on that, especially when we introduce into new interventions or when we allocate resources between different services. I think this is very of great value.